today's lecture, we are going to start with hyperinflation therapy, and we are going to start with incentive spirometry, or IS. I don't know why, when the PowerPoint transfers over to my program, why it looks funny like this, but the PowerPoint is also with this video, so make sure that you take a look at that as well. So hyperinflation therapy is something that's important to help keep our patients' lungs open. They're not at home, they're not exercising, they're not moving around a lot. So it starts towards the bases of the lungs, start to get atelectasis. We want to keep their lungs open to prevent damage and hypoxia and pneumonia in their lungs. So lung expansion therapy includes a variety of respiratory care procedures to prevent or correct atelectasis. We've already gone over a couple of these. So we have gone over deep breathing and cough. So coaching our patients with taking that deep breath in and encouraging them to cough, or modifying a breathing technique or modifying a cough. So we've already done that. PEP, which typically PEP would not be our first go-to. We would probably start with deep breathing and cough. And then today we're going to go over the IS, or incentive spirometry. We also can give CPAP, and CPAP stands for continuous positive airway pressure. EasyPAP would be another way to help prevent atelectasis, which we went over in the lab the other day. And then the last one is IPPB. And we're going to go over that in the next lecture. And that's intermittent positive airway pressure breathing. And then something else that we can encourage, it's not necessarily a procedure, but we want to encourage early patient mobilization. And this is important for several reasons. So if a patient is laying in their bed all day and they're not moving around, their body doesn't feel like it needs to take as big of breaths, so they're going to start to get atelectasis in those lower lobes. But early patient mobilization is also good because they're up, they're moving, they're getting blood circulating through their legs. So patients who are stuck in bed, and some patients can't get up. If they are in the hospital and they've been to the OR because they've had major fractures in their legs, and they're in traction and they can't move, it's understandable. If they're on the ventilator and we're unable to do any early mobilization with them, they're at higher risk for blood clots. So when the patient is able to, we want to encourage that early patient mobilization. So let's talk about some goals. So some goals would include preventing post-op atelectasis, so we want to prevent, so anytime you say ATL, that's going to be short for atelectasis. We also want to treat pre-existing atelectasis. We want to improve their cough mechanism. And we want to provide early detection of atelectasis and pneumonia. Because if we are observing that they have a decreased in inspiratory capacity, so if you notice that they're taking small, shallow breaths, it may be because they already have a pre-existing atelectasis. They've been sitting in bed for a while, and you notice they're taking shallow breaths. You want to encourage those big open breaths. So with incentive spirometry, this is something that they can do with you. The nurse should be also doing it with them. and they can do it by themselves as well. So the IS is going to supplement what we are teaching them with the cough and the deep breathing. What the IS does is it simulates, a deep breath or a natural sigh. So it simulates a deep breath or a natural sigh. So you'll talk to different RTs and different providers. Using the incentive spirometer is controversial because they may be doing okay while you're in the room, and they may be practicing it and doing it whenever you're in there. But unless they're continually taking deep breaths, it's controversial on if it works or not. Okay, so this information goes with slide 2 of the PowerPoint. It just didn't transfer over accurately for some reason. So causes and types of atelectasis. So first we have gas absorption. So this occurs when there is a complete interruption of ventilation to a section of the lung, or when there is a significant shift in ventilation to perfusion. So this could happen when there are excessive amounts of airway secretions. So say there's an obstruction because of mucus plugging. So the gas that is distal to the obstruction is being absorbed by the blood that is passing. And because there's an obstruction and there's no gas to come in and reinflate that alveoli is going to shrivel, and that gas is going to be pulled into the blood that's passing by. So it's going to collapse those alveoli, and there's no gas coming through to reinflate those alveoli. Okay. So gas absorption is what happens with complete obstruction. So gas absorption atelectasis may cause lobar atelectasis. And this can occur when ventilation is compromised in a larger airway or bronchus. So if you have a lot of gas absorption atelectasis going on, and it's not just confined, there's not just one little mucus plug in a smaller airway, but say it's a larger airway, it can cause the whole lobe to become atelectatic. And then, so this is 1, this is 2, you have compression atelectasis. So this happens when transthoracic pressure exceeds the transalveolar pressure. So pretty much that same, it's being squished. Those alveoli are being squished. That outside transthoracic pressure, the outside pressure is pushing harder and is greater than the alveoli pressure. So it's going to smush those alveoli together. And this can be caused by persistent use of small tidal volumes or general anesthesia. So obstruction is what causes gas absorption atelectasis, small tidal volumes, and general anesthesia. So the people that we are concerned most about, or are most likely, so we know that this is going to happen with them, so we can step in before it happens, are our post-op patients. And this is any type of surgery. It can be orthopedic surgery, and you have someone in traction and they're going to be in bed. So you know they've had general anesthesia. Generally, they have smaller tidal volumes when they're under anesthesia. They're unable to get out of bed. So you know, okay, let's practice preventative medicine, and let's start them doing the IS right away. As soon as they're out of surgery, the nurse or the RT are going to teach them how to use the IS. Okay, some factors associated with atelectasis. So these are need to knows. This is going to make atelectasis worse. So you're starting to put pieces together. You're looking in the patient's chart. You know they're coming out of heart surgery. They had a double bypass. And you look at their chart and you see some of these factors. You're going to know what their plan of care should look like. So know these. So with obesity is our first one. See, I like to think of it as a restrictive disease. If you have a patient who's morbidly obese and they lay down, especially supine. So supine is going to be the worst for these patients. Well, how do patients in the hospital usually lay? They usually lay on their back. The head of the bed may not be all the way back. It may be up a little bit, but they have gravity. They have the force of gravity pushing down on all this weight, and it's heavy on their chest. So it acts as a restrictive disease. If you've ever just totally pigged out and eaten too much and your stomach is just so full and you feel like you can't breathe and you get short of breath when you walk, or on Thanksgiving, you have to lay back and unbutton your pants because that stomach is sitting right there and it's pushing on your lungs and it restricts it. Okay, so neuromuscular disorders. So they have a weaker diaphragm. They're not able to take as big a breath. They chronically have smaller tidal volumes. That's something that can lead to atelectasis. If they're not generally on a mechanical ventilator all the time, this may be an indication for some sort of therapy that will help them keep those lungs nice and open, and something you can do with airway clearance therapy as well when they get their secretions up and out. If they have surgery near the diaphragm, I skipped one. Sorry, let's go back. So heavy sedation. So it decreases deep breathing. Heavy sedation decreases deep breathing. And it also decreases the respiratory drive. And we will continue to go over sedation drugs and narcotics and those drugs of that matter in emergency care and advanced pharm. So heavy sedation decreases deep breathing, and it can stop it altogether. So say you have a patient who comes in and they have a history of drug abuse. They have a history of pain pills, or you have an accidental overdose. Someone accidentally took too much, we'll say Percocet, too many pain pills. So you don't know, you're thinking in your head, okay, so they took too much Percocet. We had to give them something to wake them up real quick. So I know that they have been taking shallow breaths. I know that they're at risk for atelectasis, and I know they're at risk for pneumonia. We're going to start to put pieces together. Okay, so surgery near the diaphragm. So abdominal surgery is going to cause pain. And especially if abdominal surgery is close to the diaphragm, the closer that incision is to the diaphragm, the greater risk factor they are of atelectasis, because it's going to hurt. It's going to hurt. They're not going to want to take that breath. So that's where helping them with splinting for the cough, but also helping them with the IS and splinting. Once we do a video and we show some videos of how you do the IS, you can have them hold their splint while you hold the IS, or you can hold the pillow or the rolled up towel that you use to splint for them. But it's really important to educate your patient on why it's important to take a deep breath. They're going to be more likely to do it and really work hard on it if they know why. So you don't, and atelectasis, if you say, well, we don't want you to get atelectasis, and you leave it at that, they're going to be confused. So you want to say something like, hey, we're going to do this IS. It's that device that's going to help you take that big deep breath, because I don't want you to get a pneumonia in your lungs, or I don't want your little air sacs to get stuck together. I want you to get as much oxygen and air in your lungs as I can. It can be simple. Okay, so if they are on bed rest, and we've talked about this so far, they're not moving, they're going to decrease their amount of deep breaths and increase the amount of secretions. So if they're on bed rest, we're going to decrease our deep breaths and increase secretions. If they have a poor cough, it's a huge deal. They're at an increased risk of retaining secretions, which is going to increase the risk of that gas absorption atelectasis. So this is why it's so important to know all of our different tools and be able to put them together. And that's why after you instruct how to do pursed lip breathing or autogenic drainage, or just that directed breathing in through your nose, out through your mouth, to get them to take those deep breaths, you always want to encourage a cough. After the PEP device, you want to encourage a cough. After doing an IS, you want to encourage them to cough to get that junk up and out. If they have a history of lung disease and they're in the hospital for an elective surgery, you're going to want to make them cough. If they have COPD, you're going to want to make them cough. You're going to want them to take big breaths, and you're going to want to keep an eye out for them because they already have a history of not so great lungs. You want to get them back to their baseline as soon as you can. If they have any restrictive chest wall abnormalities. Also, you want to think about patients with kyphoscoliosis, because if they're hunched over, that's going to act as a restrictive disease. So clinical signs of atelectasis. So these are going to be key terms that you're going to look for. So if they have a history of recent major surgery, if they have tachypnea and they have smaller tidal volumes, if they have fine late inspiratory crackles. So that is a big one right there. So fine late inspiratory crackles, that's something you're going to see maybe on an exam or in a scenario or on your boards. Fine late inspiratory crackles or fine inspiratory crackles are what you're going to hear with atelectasis. So what it sounds like, if you haven't heard it yet, is if you put a piece of your hair, a few pieces of hair in between your fingers, and you rub those together and put them right next to your ear, that's what fine late inspiratory crackles sound like. Bronchial or diminished breath sounds. So if you don't hear those little inspiratory crackles, you might hear diminished breath sounds. So one area may have inspiratory crackles, or say you have an obstruction, and then so below the obstruction you have atelectasis. You're going to hear late inspiratory crackles, but maybe some of those alveoli are still stented open just a little bit. You're going to hear diminished breath sounds. So something is preventing that air and gas from going into the alveoli to hear normal breath sounds. They're going to be tachycardic because their heart is compensating for that area of the lung that is not that's not ventilating well. So it has to work harder to get blood shunted to other areas of the lungs. On the chest x-ray, you're going to see increased density, so it's going to be white. So what that means is there's going to be bronchial consolidation, or it's going to be decreased volumes and increased density if secretions block the airflow. You're going to get a chest x-ray to confirm diagnosis. So a chest x-ray can confirm, but it cannot diagnose. So to recap the chest x-ray, you're going to have increased opacities, and you're going to have a decrease in volume with significant atelectasis. So some things you need to do to help get yourself to that diagnosis if you suspect it might be atelectasis. So your patient chart. So you want to look at the patient chart. So it can give you clues, whether it's pulmonary disease, surgery, history of smoking. The chart's also going to tell you if they're obese. If you are looking at them and they're tachypnic and they are tachycardic and you can't figure out why, you're going to want to ask them to listen to their lungs, and you want to have them take big, deep breaths, because it's when they take those big, deep breaths and those alveoli are unsticking from themselves, because they have that surfactant that keeps them nice and open and smooth. But once they have the atelectasis and there's no gas moving in there, they can get stuck together. So you have them take that big deep breath in, and as they start pulling apart, that's what's going to make those fine inspiratory crackles. So patient chart, auscultation, and if you suspect atelectasis, then you're going to want to order that chest x-ray. So the IIS has been around a long time. It was first introduced in 1972 and is now a major part of the care plan for a lot of high-risk surgical patients. So remember, these patients are at a high risk for atelectasis, and them having that surgery is what makes them high risk. Not moving around, may have a history of lung disease, general anesthesia, pain, and drugs may all make them high risk. So what the IS does, and one of the important things about it, is it gives visual clues to the patient on their inspiratory volumes. So we're going to want to coach them on the proper flow, because you don't want to do it too fast. You want them to maintain a breath so that it holds the volume in the lungs and keeps the lungs open longer, and that's why it focuses on that flow. So let's talk about how the IS works. So we have this side is the spontaneous breath. This side is a breath with using the incentive spirometer. And what that purple line symbolizes is the alveoli. So on inspiration, on a spontaneous breath, you can see they're only open at their maximum volume during a normal breath for a short amount of time. With the IS, they're going to be open with the breath hold for a longer amount of time. And what this line here signifies is the transpleural gradient. And what the transpleural gradient is it's the difference between alveolar pressure and pleural pressure. So the greater the gradient, the more the alveoli expand. So the longer this line is here, the more they will expand. And it helps with the breath hold because it's going to stint those airways open. So the IS maneuver is sustained maximal inspiration. So sustained maximal inspiration equals a slow, deep breath up to or close to vital capacity with a 5 to 10 second breath hold. Now, for someone who's in the hospital, especially if they have a history of lung disease, or they're really tired and fatigued, or they're on pain medication, that 5 to 10 second breath hold may be too much for them, but you want to encourage at least 3 to 5. So 5 to 10 is optimal. That's what we want to try and shoot for. But if we need to take baby steps and keep working on this, 3 to 5 seconds would suffice. Indications, always know your indications for IS, would be if you know there's a presence of pulmonary atelectasis, if they are having a procedure or there are conditions that are common and make the patients high risk for atelectasis. So upper abdominal surgery, thoracic surgery, surgery in patients with COPD. If patients have a restrictive lung disease or are associated with quadriplegia or a dysfunctional diaphragm, we're going to want to do lung expansion therapy. So takeaways, indications. Confirmed atelectasis, conditions that'll cause atelectasis, and then a restrictive lung disease. We want to watch these patients and watch their inspiratory capacity. Are they taking big breaths? Are they taking shallow breaths? How big of breath can they take? So all patients on IS must be able to reach an inspiratory capacity of 10 mLs per kilogram of ideal body weight. So they must know this, be able to reach IC of 10 mLs per kilogram of ideal body weight. If they cannot, they need the IPPB. Or some other form of lung expansion therapy. So your hospital probably will not have IPPB, but you could start them on an easy PEP. That continuous pressure is going to help. So contraindications, always know your contraindications. So your patient has to be cooperative. If you can't instruct them or they're obtunded or they just are sleepy and they can't understand how to do the procedure properly, the treatment, then it's not going to work. So your patient has to be cooperative. If your patient just doesn't give a damn and they don't care, they don't want to do it, they don't want to put any effort, it's not going to work. So they need to be motivated. They have to be able to demonstrate the device. You're going to have those patients where you're going to try your dangdest to give them the treatment they need to help them get better because you're there to help people. That's why you went into respiratory, is to help people. And you're not, some people are just stubborn and they don't want to do it. But then you have those people who every time you check on them, they've gotten so much better because they're doing everything you said and they're rock stars. So know that you're going to have patients that are both ways. Okay, if your patient's respiratory rate is greater than 25 breaths per minute, it's not going to work. They're not they're not going to be able to do that breath hold. They're too tachypnic and you need to help them they may have bronchospasms. You need to help them get their respiratory rate down or get them into a higher acuity of care. And lastly, patients who are unable to take a deep breath effectively, even with coaching. So if their vital capacity is less than 10 mLs per kg, or if their inspiratory capacity is less than what predicted should be. So that was that if it's less than 10 mLs per kg of ideal body weight, then it is contraindicated. So the patient must be cooperative. The patient must be motivated. Their respiratory rate must be less than 25 breaths per minute. And they must be able to take deep breaths. As with anything we do, there can always be hazards or complications. So hyperventilation and respiratory alkalosis. So this is why it's so important to coach the patient and educate them that they need to be taking slow, deep breaths. We don't want them to be going too fast because then they're going to hyperventilate. And hyperventilation is the most common. So patients should pause longer between deep breaths. If they're taking big, deep breaths, we want them to pause. If they're taking big, deep breaths and they blow it off too fast, they're going to blow off too much CO2. So discomfort, if they're in pain and they haven't had pain medication, then we can cause them discomfort. Pulmonary barotrauma. So what that is talking about specifically are pneumos. Very, very uncommon to have pneumos. There is a small chance with COPD patients just because they may have little tiny blebs or little pockets of air, and if a bleb ruptures, then it can cause a pneumo, but it's very unlikely. An exacerbation of bronchospasm. So if they're hyperventilating too much, or if they are taking these big deep breaths and it may be too cold in their room and they have reactive airways to cold air, it could cause bronchospasm. Patients who are already sick in the hospital, maybe they are there for an exacerbation or they're there for post-op. And if they're on pain medication, this may just wear them out. They could just get tired very fast. So something to keep in mind is this is not effective if it's not done properly. So this is where education and proper technique and coaching comes in handy. You're going to so with the PEP device, you want to blow out into it like you're blowing out birthday candles. With the IS, you want to suck in like you're sucking through a straw. You're going to get those patients that every time you say, suck in, take a big deep breath of air, they're going to blow out. And so, you need that proper coaching. It should not be the sole treatment for lung collapse or consolidation. So if you see even lobar atelectasis, you also need to be doing PEP therapy. You also need to be doing easy PEP. You need to be doing something else to help them expand their lungs, not just IS. Another risk is also increased intrapleural pressure. So if they're taking these big deep breaths and they're really expanding their lungs, it can stimulate the vagal reflex, which can cause bradycardia. It's not as common unless you have some rock star patients that really take these huge, gigantic breaths and are just killing it. But at that point, they probably won't need the IS. So the IS itself is typically pretty simple, light, portable, inexpensive. They can just set it right there on their bedside table. And IS devices are either flow oriented or volume oriented. So volume oriented ISs, the patient inhales and the bellows indicate volume that's displaced. So the volume that is going into their lungs is being measured by that bellow going up the column. Now, flow oriented devices, typically they're more popular with kids. In the hospitals I've been to, I've seen mostly volume oriented devices. We have some flow devices at the campus as well. So there's, excuse me, there's 3 large columns with plastic balls. And so that negative pressure on inhalation causes those balls to rise, and how much the balls in the columns rise depends on how much flow is being generated. So this is an example of 2 flow devices. These are the common ones you'll see in area hospitals around here. And you can see, here's that bellow that I was talking about. So it's like a straw. You have them suck through the straw in the mouthpiece, and then as they inhale, so as that volume is leaving this column here, the bellow's going to rise up. Now remember, they have to be able to achieve, so we're going to put patient goal, they must be able to achieve an inspiratory capacity of at least greater than or equal to 10 mLs per kilogram of ideal body weight. So ideal body weight. These are formulas that you're going to have to know. So for males, it equals 106 plus 6. And then you take their height in inches minus 60. And then for females, it equals 105 plus 5. And then you're going to take their height in inches minus 50. So remember, it's important to remember PEMDAS. So parentheses first. So you're going to do this part of the equation first. So let's say, here, let me pull up a new page. Okay, let's work one out together. So let's say that we have a male and he's 5'9". So that's 69 inches. So to set up, so we'll have a male. He's 5'9". So remember, 5 foot is 60 inches. So he's 69 inches. So we're going to set up the equation like this. So it's 106 plus 6, 69 minus 60. So remember, we want to do PEMDAS. So we're going to go over here. And so we're going to have 9 So we're going to do first, multiplication comes next. So we're going to do 6 times 9, which is 54. Then we're going to do 106 plus 54. And I can't do math in my head because I'm not very good at math. So you have 160. So his ideal body weight is 160 pounds. So now we have to convert 160 pounds to kilograms. So this needs to become kilograms. So remember that 1 kilogram equals 2.2 pounds. So you're going to take 160 divided by 2.2. So you're going to move that over. 22 goes into 160. So it goes in 7 times, which is 154. So then we're left to 6. And we'll do that 2 times. Minus 44. We have 16. So we put the point. So then you're going to round up to 73. So he is 73 kilograms. And that is his ideal body weight. Okay, so let me erase some of this here. So the minimum amount that he needs to be able to achieve equals 10 mLs per kilogram of ideal body weight. So all we have to do is multiply this number by 10. So minimum amount is 730 mLs. If he cannot achieve that, then he should be doing some other form of treatment besides incentive spirometry. So we'll take this and we'll multiply it by 15 and by 12. So we'll take 73 times 12 and then 73 times 15, and that will give us our goal for the IS. So when we administer the IS, we're going to explain to the patient what atelectasis is and why it's important. We are going to say we don't want the little air sacs in your lungs to collapse, or we don't want the bottom of your lungs to get smaller. We want them to keep that oxygen and air in them. However you feel comfortable explaining it so that the patient understands what you're explaining. We're going to determine the goal. So we kind of went over this here. So determine goal. So for their goal, you were either going to do 2 times what the patient's tidal volume is. You're going to look at the cheat sheet that comes in the IS when you open it with the directions, or you're going to times ideal body weight by 12. And you guys need to know how to do that because I'm not going to give you the little cheat sheet that's inside the ISs. You need to have the patient sitting up or sitting as far up as they are able to. If the patient needs to splint because they have had thoracic surgery or some sort of surgery close to their diaphragm, they can splint as needed. It should be done 8 to 10 times an hour while awake. So anytime you see WA, it means while awake. And then after they're done, you need to instruct the patient to cough. You need to make sure that they're taking those deep breaths because we want to move around the secretions. So we don't want them to sit there, but unless they're coughing them up and out, they're going to go back down into the bottoms of the lungs. You want to make sure that when you leave the room, you leave it close to the patient so that they can do it on their own. And when you're charting, you're going to chart what their goal is, and you're going to also chart how much they achieved. You're going to chart how they performed. Were they cooperative? Did they work hard? Did they get fatigued? Adverse reactions? Did they signify that they've been working on it while you were gone since you've seen them the last time? So this is something, if you are going in to do a breathing treatment, a nebulizer, a Dulera, anything, and you're already going in to see them and they don't have one, you can grab one for them if they're at risk for atelectasis or pneumonia. If they have one, you can just ask after their treatment, hey, let's do a couple breaths on this thing. And they'll show you. You can chart what they achieved on their IS.